Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's session is entitled Living with a Diagnosis of TM, including AFM, NMO, or ADEM, as an adolescent and young adult. My name is Roberta Peche, and I am the Research and Project Manager at the Transverse Myelitis Association. We are a nonprofit focused on support, education, and research of rare neuroimmune diseases. You can learn more about us on our website at myelitis.org. Sam Huge from the University of Texas Southwestern Medical Center, TM and NMO Center, will be moderating our podcast today. A few housekeeping pieces before we get started. This podcast is being recorded and will be made available on the TMA website at myelitis.org, and it can be downloaded as well via iTunes. During the call, if you have any additional questions, please send them to us via our Facebook page at facebook.com/myelitis.
Great, thanks, Roberta. The 2015 TMA Ask the Expert podcast series is made possible through the generous support of Chugai Pharmaceutical Company. Chugai Pharmaceuticals is conducting clinical studies to create original and innovative drugs, both in the United States and overseas, to address unmet medical needs in neurological disorders where the level of pharmaceutical contribution and satisfaction concerning patient treatment remains low. We are thrilled today to be joined by Dr. Lana Harder and Audrey Ayers as experts on today's podcast. Dr. Harder serves as a clinical neuropsychologist at Children's Medical Center, Dallas, and is assistant professor of psychiatry and of neurology and neurotherapeutics at the University of Texas Southwestern Medical Center. She is board certified in clinical neuropsychology and specializes in the neuropsychological evaluation of pediatric patients with disorders of the central nervous system. Dr. Harder's research interests include cognitive and psychosocial outcomes for pediatric demyelinating diseases. Audrey Ayers is a clinical nurse in the Multiple Sclerosis and Neuroimmunology program at the University of Texas Southwestern Medical Center in the role of primary nurse for the Pediatric Demyelinating Disease Clinic at Children's Medical Center, Dallas. Along with her clinical duties to adult and pediatric patients, she is also the coordinator of the Pediatric Demyelinating Disease Program. In partnership with a consortium of multiple sclerosis centers, Audrey has recently led a board of neuroimmunology specialists to create the certification examination in rare neuroimmunologic disorders, the CRND. Now, before we jump into the questions, I was hoping that Dr. Harder, that you and Audrey can speak to your role with this topic today. What makes you interested and qualified to really speak to what it means to live with one of these diagnoses as a teenager and moving into adulthood? So, Dr. Harder, if you could explain a little bit of your experience in this to start us out, that'd be great.
Absolutely, and thank you, Sam, for that introduction, and thank you to the TMA for having me today. I currently serve as a co-director for the Pediatric Demyelinating Diseases program here in Dallas at Children's Medical Center, and have been a part of this group since it opened. So we opened in 2009, and over 6 years now we have been serving our children and families affected by pediatric demyelinating diseases. I would say that in our multidisciplinary clinic, that transition is central to our mission. We have successfully transitioned many patients over the years. I'm happy to say we have lots of our patients who are out in the world, at college, in the workforce, really thriving and managing their medical condition. So I've had a lot of experience over the years becoming acquainted with these conditions and also helping our patients pursue their goals and move through life the way that they'd like to. I also, as a graduate student at the University of Texas in Austin, worked in the disabilities office. So our office was Services for Students with Disabilities, which is an office that you would find on probably just about every college or university campus. And my job there was to review documentation of disability and help students determine what type of accommodations they would need in their years at college to make sure that we were addressing those needs according to the Americans with Disabilities Act, to make sure that they could pursue their college careers alongside their unaffected peers. So transition and the topic of transition is very near and dear to my heart. I've been able to merge some interests both in transition to college as well as pediatric demyelinating diseases, and so it's given me a unique perspective on how we do this, how we go about this. So again, I'm delighted to be here today.
Thank you, Dr. Harder. Audrey, could you speak to your specific interest in today's topic?
Sure, and thank you as well for the kind words. And so I came on board in 2012 and have been part of the team since then. One of my special interests has been transition since I came on board, and so we created and piloted a transition of care program, which now we have expanded with the entire Children's Hospital to create a transition program across the whole hospital system. So we are working on this daily to try to improve and take what we've learned over the years to create a program that works for the families and the children to help them learn how to independently navigate the adult healthcare system as they grow into their young adult years. Yes,
so it sounds like there were a number of questions that were asked that really fall into this category of what we call transition of care, which to the community out there is really preparing and equipping children and adolescents to, like you said, Audrey, to enter the adult world and manage their medical issues as adults. And so a number of questions, like I said, kind of fall into this category. So I want to start out with one that can lead to a pretty good discussion here, I think. What resources are there for me to help transition to living on my own when I go to college and move out of my parents' house? So Dr. Harder, could you speak to that first?
Sure. So as I mentioned a moment ago, there are federal laws in place that protect individuals with disabilities. This certainly covers the higher education environment. And so I think it's important for people making that transition to college and just in general to adulthood to become familiar with their rights and to become familiar with the ADA. On a university campus, there are lots of different resources that we recommend our patients are checking out and becoming familiar with, and we really suggest looking into these things, identifying these resources ahead of time. So it's ideal if these can be scoped out, say at the orientation level or even before that. So getting online is a great place to start, looking at the university website. There will be an office that would be called something like Services for Students with Disabilities or the Disabilities Office, where a student can kind of get started with the process. So typically it would involve making an appointment and going in and talking about their specific case, their specific needs, and then from there that office can get the student plugged into all kinds of other resources on campus. So I think that's a great place to start. They can talk to the student about issues around mobility, getting from class to class, the dorm rooms, just general campus life, but also can address needs related to academic accommodation. So if a student in high school had received academic accommodations for any reason, say they got extra time for something, a reduced distraction environment, those are the kinds of things that can extend over into college, which we find can make a big difference for students as they make the transition. So those are some of the things that come to mind. I mean, it's a big transition for anyone, for our students without disabilities, but we know that there are additional challenges that are often associated with a disability. So we really recommend being as proactive as possible to get plugged in to those services early on, rather than arriving on campus and sort of trying to wing it without any help, and then sort of in a crisis having to go and seek out those services. So just having them in place at the outset of college, I think, is really ideal for students.
A follow-up question to that, a number of our pediatric patients do, like you mentioned, get support services in their high school setting. Is there any services that they might legally be allowed in high school that they might not come across as being allowed to have in the university setting? Is that more university or institution specific, or is it really under a more federal law?
This is a great question and a really important distinction to make, particularly for our students making this transition. So in a high school environment, there are many more modifications that can be made to a student's work based on their support plan that is in place. At the college level, students are expected to meet the same criteria as their non-disabled counterparts. So basically what this means is when the student graduates from college, their degree is going to mean the same thing as someone without a disability. So the idea with academic accommodations in a higher education setting is that we are not modifying the work in any way, but we are accommodating the disability. And the best example of this would be we would give someone in college extended time to complete an exam, but we cannot modify that exam in any way. So in other words, the student is finishing the same exam as everybody else. They may get that extra time to what they say is even the playing field. So those would be some of the differences that we see. But a lot of times there can be some concern about, getting accommodations in college. How does this affect, admissions or the degree plan? But we like for folks to know that, your disability documentation and information about that they're protected in a similar way that medical information is protected. So this would never come into play at the admissions level or through the registrar. This is never reflected on a transcript or a diploma. So these are services that they can get that they work directly with the disabilities office to achieve.
That's great. I think that's important clarification. Moving on to another question, Audrey, I think that you could help answer this. I'm not 18 yet, but I want to make sure that my doctor keeps our conversations between us and not between him, me, and my parents. Am I, even though I'm not 18, entitled to have this type of confidentiality with my doctor?
So it's an excellent question. And to be honest, I really do think that there are various state laws that are going to regulate some of these conversations a little bit different. So it's always good to know the regulations and laws that are within your own geography. I know that within our clinic, once a child is moving into their teen years, we always try to start having separate visits with the physician alone with the patient, and then bringing mom and dad back in at the end and giving the child a chance to kind of speak independently and on their own with the doctor and start to build that trust relationship, because it can take some time. I do know that if there is ever a concern for patient safety, that it's up to the prescriber's discretion in order what to share with mom and dad. As they are still under the age of 18, and so they are still a minor, and if there's any risk of harm to themselves or to other or that kind of thing, that they would have to bring the guardian in to bring that conversation. But that's always something that you want to have a very good open relationship with your prescriber and learn about communicating not only with your medical team and learning how to do that. It can take some time, especially if mom and dad have been communicating with them for many, many years, and then learning how to then take what we need to back to mom and dad. And so just building that relationship with your medical provider and having that time to have an independent visit and then coming back with mom and dad are good ways to start practicing that out. Just knowing that there will be some things, and your prescriber should talk with you about this, about if safety is ever at risk, that they're going to have to open that door up and bring the parents in. Yeah.
As a follow-up to that kind of question, falls into that category of confidentiality and private conversations with the physician. There's a question, I'd like a chance to talk with my doctor privately, but I'm afraid my parents won't like it too much. How should I approach my parents and doctor about this? So this question of the adolescent wants to have some private time with their physician, but the parents might not be as interested in it as they are. What's any tips or ideas from either you, Audrey, or Dr. Harder on engaging the whole family in the transition?
Sure, I can jump in first. This is Audrey. I think that part of that is, again, building trust and bringing down anxiety. I think it's a good idea to practice starting to having the child have conversations with their medical team independently, because these disorders, they are going to be with us lifelong, and so giving the opportunity to start having those conversations when we're younger is going to build a good relationship. And so we want those things for our kids, and we want them to be able to feel comfortable talking with the doctor, because there may be a point in time where if they move away to college or if they move to a different town and different things like that, we're not going to always be there. And so I think this is, again, where communication is going to be really big, and just saying, it's not anything against you, Mom or Dad. I just want to have a talk with the doctor. And a lot of times that can be done first, and then the doctor can bring the parents in after they share what they need to. And I don't know if you have anything to add, Lana, from your side.
Yeah, I agree with everything you just said. I think it's a great sign when actually it's the parent's idea. Oh, did you want to talk to, Dr. Smith alone? And we do see that sometimes, and I think it really comes from both sides, the patient and the parents, that it can be something that either can suggest, and I like this point about how getting the patient to speak directly to the doctor is really excellent preparation for this transition to adulthood, when providers and people working with the new adult, the young adult, won't want to speak to parents at all. So I think that's a great way to kind of couch it too, is this is preparation for that transition.
Mm-hmm. So what about the flip side to that question, where the parents or the guardians want to foster this independent relationship of their child with their medical team, but the adolescent patient is not wanting to cooperate and doesn't want to take on the responsibility? How would you recommend managing that kind of situation?
So I always say we start small outside of a crisis. So when things are routine, like we're going to get a refill, or we need to make an appointment, or these kinds of things. And so, we can have a lot of anxiety when we're talking to someone we've never talked to before. We're having to use the phone and share some information, and maybe talk to a stranger. We don't know who it is who's answering the phone. And so I always say, let's start small, and I always encourage people to call together. So maybe the first few times it's come with me, and we're going to call the doctor's office on speakerphone. And we do that for a few times, and they get to be familiarized with what's happening on the other end of the phone. And so then it becomes a little less scary, kind of just by exposure. Then as we move up into when things get more serious, maybe there's a symptom or there's something going on, then we continue to have those shared conversations until the patient is able to kind of take a jump out there and make the phone call themselves. One other thing that we really like to utilize, because I find that our adolescents really like to use their phones and email and things like that, is our facility has a secure emailing system, so that they feel more comfortable typing a message to me sometimes than they would be calling and leaving me a message on a phone or talking to a stranger. And so that's a good medium way to use the technology to help them feel more comfortable with conversing with us. But there are going to be times when it's a good idea to push them a little bit, because if they are thinking about going to college, or they're thinking about moving away or starting something new, and we talk to them and they don't know how to refill their pain medication, or they can't make an appointment. And there's going to be a lot of anxiety. And we think of all the challenges of moving away from home or trying to do things independently. If we don't have some of these basic skills down, it's going to make the hurdle of transitioning into the next stage of life that more complicated. And so I always encourage people to start really early. We start at age 13 and just say, hey, the next time you need a refill, go with mom to the store or call me when you need to change the appointment. And even if I call them back together or just talk to mom, just them practicing that skill I think is really helpful in building their confidence over a long period of time. And I think it's been very helpful for our group of kiddos.
Yeah, I agree with that. And I wanted to make the point relative to college that when I did work in the disabilities office at UT, we would get calls from parents, especially that first year of college. And we'd have to say, I'm so sorry, we actually are not able to speak to you about this, because actually the student was 18 or older, so there were some legal implications there, but we had to say politely to the parent that actually your student will need to call us directly. And once the student did present to our office, we sat down and really expected them to be able to tell us what we call the functional impact of their disability. So how does your disability affect you day to day? So I would say that's one of the most important things, especially for someone going off to college or starting in a job, to be able to say how it is that a disability impacts them, so that the college or the employer will know what types of accommodations would be needed. So I think having those conversations, practicing. I know when I see my teens for evaluations at Children's, that's just part of the conversation we're having. Is I always say, well, how would you explain this to somebody else? How would you say this condition affects you? And just getting them to put that into their own words, and then have opportunities to practice, like Audrey said. I think those are the best ways to kind of get started on this.
Yeah, I think that's an important point. First, that baby steps are key in most things, including transitioning from adolescence to adulthood. But also, Dr. Harder, like you were just saying, being able to explain not only your diagnosis, but what that means to you on a day-to-day basis and how that really affects you. There's another question. I'm heading to college in the fall. I'm afraid of people staring or asking me what happened or what's wrong. How do I explain what happened? Do I have or did I have a disease that made me this way? Do you think, Dr. Harder or Audrey, do you think you could speak to kind of how one should be expected to express themselves and their diagnoses to new people, either in the college sphere or in a new workplace situation?
Yeah, I can speak to that. I think just like we've been saying, rehearsal is really key. I think when a young person is confronted with stares or questions, we always advise to them that just be ready to have whatever your answer is. I recommend keeping it pretty short and simple, and factual. So, I had a spinal cord injury from an inflammatory disease, and it's affected me in this way. Kind of just keeping it sort of to the point. Maybe not staying too long on the topic. Certainly, if there were questions, I think it would be great that the person is kind of prepared for that. But being able and ready just to move on to another topic, changing the subject from there. But I think having that initial response is really important, and we find that's helpful and comforting to our teens or young adults who are put in this situation.
And I want to add, too, that this is a very personal decision. And so, take time to, as you're rehearsing and kind of thinking about what you want to share with others, take time about really how much detail you want to share. You don't always have to feel obligated that just because someone asked you, you have to tell them. And so learning, who you trust with your information is really important. So sometimes there might be just a light, easy way to kind of quickly respond to someone and change the subject. And then sometimes there will be times when you want to share more about what's going on with your life. And so, it's okay to talk about this with your medical team and or your family members to kind of gauge, how much do I want to share with this new person or with this new employer or my school and that kind of thing. And so don't always feel compelled to having to share all the details until you feel ready to do that, knowing who you can trust and who you cannot, okay?
Yeah, I really agree with that point, that it is, you're going to share different levels of information depending on your relationship with the person. And I also think it's important, I know at our TMA camp and other settings here at Children's, we're able to talk about these conditions and what we expect in the future. Is something chronic? Is it a one-time thing that we don't expect to come up again? I find that there's a big need for education, just in general. And so utilizing the resources on the TMA website at, I believe, mylitis.org to really kind of get more information, watch some of the videos, hear how other people are describing it, I think can also just give a good foundation for how a person might talk about it.
Mm-hmm. I think that's important. It is cliche, but knowledge is power in this way, and we're our own biggest advocate. So the more that we can understand about our own health needs and diagnoses, the better we can explain to others if we choose to inform them of what's going on. Moving on to another question, this is a question that I think is pretty straightforward on the surface, but I think it can get into some deeper conversation. Very simply put, when should I start seeing a physician that focuses on adult patients? And while the easy answer to that seems to be 18 years old, 18 to 20, or whatever per laws and regulations, when I read that, I think about with some of these kids who've been seeing their pediatrician or their pediatric neurologist for maybe the bulk of their childhood, and somebody that they might have become close with, and then all of a sudden when they're 18 or 20 years old, they're forced to go find another physician to take care of their disease. I think that could have some scary impacts. And just wondering from you, Dr. Harder and Audrey, what your thoughts are on the transition process from existing physician, pediatric physician, to adult physician, and how can we make that process as smooth as possible?
Sure, I don't mind jumping in first. This is Audrey. So I think to make things as smooth as possible, start early. That's kind of my main theme here is start early. It's always easier later on. But no matter where you are in this, just start communicating with your team and making plans. So it's not a simple question in terms of when to transition because there's a lot of factors. One big one I know that we talk about with a lot of our families is insurance. And that's going to vary family to family, individual, based on maybe parents' insurance, maybe the state health plan that they have, maybe what's coming down the road, and what provider takes what insurance. So a lot of our children will come straight from our children's clinic to our adult clinic. Some of them will go over to various different doctors depending on if they move away from school or if they have different issues with access to the office. And so that's going to vary. And so that needs to be a conversation probably starting to have earlier rather than later, just because we don't want access to be determining all of our decisions for us. There's also different things about access to other providers. So we know that with some of our patients that, like Dr. Carter, wants to be with our young people going through to school and different things like that. And so we may keep our children there in our children's clinic for longer based on just access to her and the services that she can provide for them as they're moving through school. And then we want to make sure that the doctor that we're moving to, we can start building that relationship with. And so usually what we will find is that our patients will move into an adult primary care provider first and start establishing care there. That happens typically around age 18 just due to the rules around pediatricians' offices and things like that. And then we will start preparing for that transition. And we usually take about 6 months to a year for that final transition until we make the appointment and know that everything is going well. So it's going to vary family to family, but start early, plan for when that adult time period comes, because we just never know what other factors may be there. And then start working with your adult provider. And sometimes you may make an appointment and come back and see your previous doctor one last time before you finally transition over. So it's going to vary, but just open that door of communication with your team to try and set that up smoothly as you move into the next stage.
Mm-hmm. Dr. Harder, do you have anything to add to that?
I just echo the points about starting early, setting up mechanisms for shared information, signing a release, allowing communication between the pediatric provider and the new adult provider, and then keeping your, own records that you can bring in the event that somehow there was a breakdown between providers. But I think all of those things can help make the process a little bit smoother.
Mm-hmm. I'm going to shift gears a little bit. There was a question that I think is kind of important to this population of teenagers and adolescents that's more medically bent. What impact does puberty have on my transverse myelitis, and what changes should I expect compared to my peers? Audrey, do you think you could speak to this first?
Yeah, sure. I can jump in. So everybody's going to be a little bit different. And depending on just kind of if we had NMO, TM, and just kind of the way that the diagnosis went in the beginning, there's going to be varying levels of what this is going to look like. One thing I always like to kind of point out to our young teens, especially our female teens, is that there are going to be some hormone changes that happen in our life, and so that can affect our symptoms, fluctuating and different things due to the heat changes from the hormones. And so I always like to kind of let people know so that they don't get surprised by that when that happens. And then there's just going to be, as we move into adolescence, and maybe we have different questions about what things going to look like into young adulthood, about having a family and different things like that. And so I always encourage, and this can too partake in that conversation you have with your provider individually, but, is to start having those questions with your doctor. So if you're worried about what's going to happen in the long term, about moving into adulthood and having a family, or can I, and all those kinds of things, I always encourage people to ask those questions, because almost everyone's thinking about it and they may just be too afraid to talk about it. So finding one of those medical professionals, whether it be your pediatrician or your neurologist, your PM&R doctor, and just having that conversation about, this is my body and I just want to learn more, and tell me what is going to be affected in the long run. And so again, communication is key, and just talking about our questions, our fears, different things that might be there, because usually the fear is much bigger and scarier than actually what reality is. So always good just to talk and get those things out there.
Yeah, I think that's important. And moving into, like you said, communication is key. There's a grouping of questions here that I think I'll kind of hit on the same kind of thing in terms of family dynamic and family communication. So one being more from the parent's perspective, my child will no longer talk to me about how he's feeling about his life or diagnosis or complications. I'm afraid he's depressed and I don't want him to become isolated and sad. How do I get him to talk? So this whole concept of adolescence and becoming an adult and the depression that might go along with the anxiety of adolescence, compounded with anxiety and depression from a possible a medical condition. Any recommendations or thoughts that you have about how to handle those situations as they arise? Dr. Harder, would you like to start?
Yes. And this sort of ties back into the question on puberty. I always am coming at this from a developmental perspective. So what do we expect of any person at a given age? And when we're talking about adolescence and what we call emerging adulthood, the job of teens and young adults is to grow in their independence, right? To become their own person, to detach in some ways from parents and kind of becoming their own individual who is becoming more and more independent and taking care of themselves and things of this nature. So when there is a medical condition like the ones we've been talking about today, there's a conflict has been created. So you already have the typical challenges associated with puberty and the teen years and growing up, but now we have inserted something that requires the teen to need more help and more support. You can see the conflict there. They're trying to do their developmental job of becoming more independent, but now are being put in a position where that's really compromised for them in many ways. And so this is an added challenge, and I think it's important for parents to be mindful of this thing that's going on, and to be kind of expecting that a teen may not want to talk about everything and may not share everything maybe as they did when they were younger, and that's okay. At the same time, we have to have good, clear communication among family members, particularly as we navigate a really challenging circumstance and manage a medical problem. So one thing that has been very helpful to some of the patients that we work with is actually a family therapy approach where everyone can get in the same room with an objective third party who can help talk through these things and work through these things. So particularly if the problems are not something the family can work out amongst themselves, having that independent, objective person in the room to help work through that, I think is really key. And for anyone that suspects that someone might be depressed or really struggling emotionally, I think it is worth consultation with the person's medical team and possibly with a psychologist to see are the symptoms reaching a clinical threshold, meaning that it's really interfering with daily life and the family, to see if services are warranted. So those are some of the thoughts that I have in hearing that question.
Audrey, do you have anything to add?
No, I think those are really, really great points, and we've seen a lot of successes just with families being able to have such enhanced communication by having that family counseling. It's been really a great thing that we've seen with a lot of our families, and so if that's something that hasn't been tried, it's definitely worth investing some time, and it doesn't mean forever always, but it can be. I kind of think about putting things in our toolkit that can help us for later on, and so allowing everyone a chance to kind of be voicing their concerns, to feel heard, and to have a space where they feel safe to talk about things that they may not be able to feel like they can communicate well in the home environment as it's changing over time.
There's a kind of the other side of that coin is asked here as well. We've been talking about the possibly depressed or anxious adolescent or child and how that affects how the parents or guardians should approach that. But there's also a question on the other side. My mom is constantly asking how I'm doing since my diagnosis, if I want to talk about things, if I feel like I need to talk about what happened. I don't want to talk, and I don't think I need to. How do I get her to stop worrying and leave me alone? So this whole concept of maybe the worrying or over-anxious parent and how to communicate in that way from knowing the independent nature of the adolescent and trying to function in that way. Any other recommendations or different recommendations that you might have?
Sure. So I'd like to say, I think it's perfectly natural for parents to have this, desire to check in a lot and repeatedly when a child has been through something like this, and even in general, because the teen, it's not uncommon for the teen to sort of withdraw, like we said before, and not share as much, and that we consider that to be pretty typical for someone at that age, and we say to that's okay. At the same time, parents feel that they need some reassurance about how their child is doing, and I think maybe lowering the frequency with which they ask about the medical related factors or the medical condition, and maybe talking about other things and engaging their child in conversations about things they know that they're interested in that are maybe safer topics. And that would be a great way to kind of get a sense of how their child is doing, and also just through observation. I think it's always a good sign when we see our teens engaging in things that they enjoy doing and taking pleasure in social relationships and other activities. So there are other ways besides getting a verbal response from a teen to sort of see how they're doing, making sure that they're continuing to do as well as they ever have with school and with other things like that. So where we become a bit more concerned would be, as I mentioned before, is if this starts to interfere with daily life, daily functioning. So you see sort of a downward turn, maybe relative to social relationships, overall like mood presentation, or their ability to do things, at school, or in terms of household things, taking care of themselves. So those are just some things that come to mind there.
Mm-hmm. Yeah, and I want to add, when we see our teenagers adapting and growing in their skill set with certain things, like remembering to take medications independently, or reminding, hey, I need to call and make an appointment. Things, and they sound very basic, but I think as we build these skills, and those are the beginning, that the parents' level of concern and anxiety usually comes down. And they don't feel the need to check in as much because they're having this confidence that their child is being empowered and they're feeling independent, and they're seeing them kind of grow in their skills. And I just want to say that even when we start to gain some of these skills, we build our toolkit up and we're doing some of these things more independent. It is normal, completely normal for it to be, we can gain some things and then kind of backtrack a little bit. So I take a step forward, I take 2 steps back, and maybe that's because of a recent hospitalization or something else stressful is going on in life. But what I think we're doing is within the safety net of the family home is allowing them to try some things, maybe fail, maybe not do as well, and then figuring out how to be flexible and find a way to kind of overcome that challenge, because we're all going to face challenges in life, and things may be probably more challenging if we have other things going on medically, and so we want to try those things out in the safety of our environment, where we can kind of catch them and help them build up their confidence again as they go through the years, so that when they're going out on their own, they don't run home at the first sign of failure. And so I think as the parents see these kinds of things, that they may not feel the need to check in quite as much, like verbally, like Dr. Harder was saying, and so that will overall help the bigger picture with them gaining progress over time.
Mm-hmm. I can't help hearing you both discuss this, thinking about our own experience with the Transition of Care program here at UT Southwestern and Children's that Audrey has put together, and kind of the data that we've been able to collect, and what we're looking at, and looking at the parents or guardians' thoughts and rankings on how prepared they think that their child is for transition, or what their depression or anxiety levels are, versus what the child thinks of it versus what the provider thinks of it, and the disparities between the three. Audrey, do you think you could just speak a little bit to that, and kind of the importance of communication, reiterate the importance of communication amongst the three groups?
Yeah, sure. So we took about a little over a year, and every time our kiddos came in that were 13 years above, we did an assessment of the parent, the child, and then I did my own assessment of the child. And what we were looking at was, do we think that the child can do this task independently? And some things were being able to communicate about my medical diagnosis. So I have NMO. Can I explain that to somebody who doesn't know me in a medical field? Do I know my medications? Do I know why I take them? Do I know how to refill my stuff? Do I know how to get my insurance? All the kinds of different things. And so what we did is we asked mom how confident they were that the child could do this independently, and they had to rate things 1 to 5. We asked the child about their own abilities, and then we did the same. And no one was in line. In fact, they were usually complete opposites. So sometimes the parent thought that the child had no ability to do any of these things, and the child felt very confident, or vice versa. And so what it did for us as a group was to kind of dive in and say, we're not on the same page. Let's talk about this. Do you think that you're able to take your medications on time and remember to get your refills, but your mom doesn't seem very confident of this? Let's talk about what that looks like. And so then you really got into what things look like at home and some practical tips for how to make that better. And then we could implement a goal and an intervention, and then over time we would see that improved. But had we not had that assessment and that conversation, I don't think that anyone really would have known. Everyone just was kind of going on their own assumptions. And so I think we've all learned a lot as we've gone through these visits, just based on things, people just not asking the questions. And so it's been really helpful and very eye-opening for us to see where the parents are and what they kind of evaluate things going on, and then where they think they are. Because a lot of times they will reveal, well, I want to do this, but, I don't feel like I can, or I don't really want to do this because my mom takes care of it and does everything. But that allows us to kind of dig in deeper and find out, hey, you want to go to college next year. How are we gonna do that if you're not doing this skill or this task or being able to have this knowledge on your own? And it can be simple as, I'm in a wheelchair and I need to know how to do my laundry when I live in the dorm, and what happens if something happens to my wheelchair? What am I going to do while I'm away? But without assessing their abilities and knowing what to do, we don't really know how to intervene. And so very, very eye-opening. So I encourage everyone to really dig in and ask the questions. And if we need help learning what questions to ask, we can always provide that for people.
Yeah, I think that's an important point. One other question before we close out the podcast today, I think is kind of sensitive to a number of people, adolescents, in terms of interactions with their peers at school. How do I get the other kids at school to just see me as one of them, and I just want to be with them as much as anyone else does? They seem scared of talking to me. I can still hang out with them. How do I get them to see me and not my chair? I think that's something that's a hard question to answer, but it's really getting to the point of interacting with our peers and maybe seeming different, but how does one cope with that kind of stressor in adolescence? Dr. Harder, do you think you could speak to that?
Sure, yeah, and as you said, it is a hard question. I think I pick up on a few things in the question that I'd like to address. First of all, what I'm going to say sounds really simple, but just being yourself. I mean, I think that's so important with the point about how do I get them to see me, for who I am. And so being yourself, and along with that, we kind of touched on this earlier about how if you do choose to share this information with your peers, that you are in charge of how much you share, if you share at all, if you want to go more in depth, but moving on to something else. So after explaining as much as you want to, if that's relevant to the conversation, moving on to other topics, finding shared interests. I think the more that can be done, the more people can connect on a level of a shared interest, which I think is really important. And a college environment is great for that too. There are lots of different ways to get involved with people who have these common interests, and so those are different campus organizations might be a great way to facilitate something like that. One of the other things that stands out to me about the question was they seem scared of talking to me, and so it's interesting to think about this idea from a few different standpoints. It could be that the individual, may not have had exposure to a person, say, in a wheelchair, or it's just something new to them, or maybe there are concerns about is there a medical condition. We get the question each year at camp, or we have the discussion with the campers and the siblings about, are these conditions contagious, right? So that may make a lot of us really laugh to hear that idea. But it turns out, and we collected some data on this once, that there were not very many, but a couple of people, even in the families of, so this was among like siblings and those affected themselves, had endorsed not being sure about that point if these conditions are contagious. So when I see something about fear, that always pops into my head based on what we've learned at camp. So even addressing that point head on, if that were something that might be on another person's mind. But we can't control what other people say and do and think. Of course, we can only be ourselves and choose to share the amount of information that we're comfortable with. But again, the idea of moving on from that topic, the topic of a medical condition, and talking about things that make the person who they are, and the things that they care about, the things that are interesting to them. So, I think those are great ways to reach out and get to know other people and find commonality there.
Mm-hmm. Yeah, I think that's an important point. We can't control other people's reactions. But we can control the way that we present ourselves, regardless of whatever might be surrounding the issue. Audrey, do you have any thoughts to add to that?
No, I think she really covered it really well. I think it's we just getting to know people and getting into circles is just going to take us sometimes taking that leap of faith and taking the first step and talking to someone, inviting them to somewhere, just kind of sometimes it takes that, and we may make a best friend out of it, and sometimes we don't, but I think it's doing that during adolescence can be challenging for everyone, and so just continuing to try and finding someone that we can build a safe friendship with. I think it's just good to get out there and try and build that relationship, over time.
Mm-hmm. Very true. Well, we're getting to the end of the hour here. I just wanted to wrap up the podcast with any final words or overarching thoughts or takeaways from the podcast today. Dr. Harder and Audrey, if you have any final thoughts, final words for the community about this topic.
I'd be glad to start off. I think transitions are challenging, and transition to adulthood and independence is challenging for everyone. And as we've talked about today, there are additional challenges that come with living with something like TM, ADEM, NMO. And so, to acknowledge that is really important, but to also say that it's okay, to stumble. It's okay to, to have frustrations and be upset by things. We want to make room for the human experience, with or without these conditions. There are going to be bumps in the road. There are going to be an emotional response to things. There will be different challenges, and so I just want to say that it's important to think of what is typical for anyone who's a teenager or anyone who's trying to grow into an adult. And I can tell you from years now working in this clinic and watching our patients transition that we just see really amazing things, and we see our patients go on to do the things that they have wanted to do throughout their life before a diagnosis of a demyelinating condition. They've been able to keep those goals and pursue them, and be quite successful. So I say that as a word of encouragement to our community, and I just want to thank the TMA again for having me today.
And I'll add, just I think it's important to dream big and get back on the horse when we fall off. No matter if we have things like NMO and TM, ADEM, these things or not, we're just going to have to sometimes learn from what happens and the challenges and just get back out there. Like Dr. Harder was saying, we've just seen some really great success stories of people pursuing their dreams, and they may not always look like what we thought they would in the beginning, but sometimes it's even better than what we could have dreamed. And so if there are questions or fears or things that we're worried about, things we want to learn how to do, engage your medical team, engage people at the TMA, other friends, talk with people who've gone before you, and learn how to do it, how to do a workaround, how to make it better. If there's a piece of technology, a resource out there, we know more by getting together with our community and learning from each other. And so we're going to have good days and bad days, and we want to just have people around us that can continue to encourage us so that we can become whatever we want to be and reach our full potential. And so I'm so encouraged by everyone that get to work with and meet, and I'm so grateful that the TMAs let us come on and talk about this really important topic. So if anyone ever has questions, they always know they can reach out. But I really applaud all the hard work that everyone is doing. Y'all are an amazing group of people.
Yes, thanks to the TMA, and thank you, Dr. Harder and Audrey, for your time and expertise today. Thanks to Chugai Pharmaceuticals for their support of this podcast series, and most importantly, thank you to the community out there, all you listeners, your questions and your attention today, and look forward to the next podcast announcement. Hope everybody has a great week.